Okay, so it's July 21st, 2022, and I'll let you go ahead and give your background, Allison, and swipe away these meeting controls.
Thank you.
There you go. I guess it does pull up there. Yeah. Okay, I think we're good. Awesome. Okay, guys. Great. Awesome. Hi, everybody. And hi, everybody on Zoom. If you can't hear me or if the slides aren't appearing for you, please just put it in the chat and we'll try to take care of that. My name's Allison. I'm one of the anesthesia attendings. I'm one of the cardiac attendings, so I'm more frequently over at the CVC, but I was like UH Gen Call last night, so I come over here occasionally, usually on Saturdays or call. So I flow through here every once in a while. But today I'll be talking to you about the trajectories of recovery after intravenous propofol versus inhaled volatile anesthesia. And if you pick your letters correctly and add an H, you get Thrive. So it's a little creative spelling, but that's the name of the study. And that's different than the Thrive oxygen device that we use back in the OR sometimes, or maybe even in PACU. This is a study comparing propofol-based or TIVA versus volatile anesthesia. And I'll go through some background of the study and kind of why we're asking this clinical question, and then go into kind of what to expect from your perspective. And any asks of you all are quite minor. It's more just don't blow the secret of the randomization from that standpoint. Both Satish Kumar and I are the site PIs or the principal investigators. So we're helping run the study here at Michigan. And then the main PIs are Dr. Ketterpal or Sachin, who you may know, and Dr. Avedon over at WashU St. Louis. He's the chair of anesthesia there. So they got a big grant from the Patient-Centered Outcomes Research Institute to answer this question of which is better, total IV anesthesia versus volatile anesthesia, as far as patient recovery and patient reported outcomes, which is a very understudied area. So, oh, did they say you can't? Yeah, they can't see that.
So display settings. There. All right, is that better? Thank you for alerting us.
In the chat, or Mike, if you want to text me, let me know. Can you see this second slide? It should say general anesthesia in like 3 colors. This happens to me.
Yeah, we're good now. It advanced the slide.
Oh, perfect. Thank you.
Okay, cool.
I appreciate you letting us know. You didn't miss much. There was just the title slide earlier. This one. This just said the name of the study.
Present our view. You can't.
It's so odd. Yeah.
It doesn't record. I think it happened. We did yours. It only recorded the first slide.
Oh, gotcha. Well, so this is the Thrive study. I'm glad you guys could hear me though. So we kind of talked about the general overview. And so for general anesthesia, there are 2 main options to do full general anesthesia. There's volatile based, which has been around for a very long time, 1846 to be exact, with good old ether that thankfully we've progressed away from. And then propofol has actually been really recent. I didn't realize how recent it was developed, 1977. So like within our lifetimes, this was developed, which is pretty wild that it's something that we use all the time in the operating room. Yet, even though there's these 2 different ways of providing general anesthesia, if you look at general practice in 2021, 80% of general anesthetics were volatile based and only 20% were propofol based. And if you look at kind of the anecdotal evidence of what we do differently, say at East Ann Arbor or Brighton for outpatient surgery versus here, there is a difference in how we as anesthesiologists do things. We do a lot more propofol-based anesthesia out there because we think people recover faster. Yet, there isn't a lot of data supporting that, and it hasn't really been studied in depth. So we really have no idea which is better from a patient's perspective of their quality of recovery, both in the PACU, but also when they leave the hospital. So there are big gaps in our knowledge. There's some advantages of each one. So we were talking about this earlier. For TIVA, we know that there are better side effects of decreased postoperative nausea and vomiting, and overall less grogginess. But compared to volatile, we know that that's really predictable. There's something called a MAC that was very common across people about their depth of anesthesia, which that doesn't really exist with propofol. It's a lot more, the doses range a lot more based on age and weight.
And so volatile is a little bit technically easier to administer. But there are lots of gaps in our knowledge. One is awareness risk. Another is cognitive recovery, sense of well-being, post-op pain, ability to communicate and return to usual activities, and sleep well, enjoy food and not be nauseous, which are all key things from a patient's perspective that we don't always see in completion here in the hospital, especially for outpatient surgery. And so to answer these questions, this is where the Thrive study was kind of born or proposed. And so the big version of this study is randomizing over 12,000 patients across 12 to 15 centers to either receiving propofol tiva or inhaled VolatilE anesthesia, and then measuring these quality of recovery, functional status, activity levels, with a subset of these folks getting daily wearables to see how their activity changes, and then also measuring kidney injury, respiratory failure, mortality, and then especially awareness with recall. And so these things are going to be assessed on multiple days from day 0 in the PACU all the way up to 90 days after the procedure. And these will all be conducted by our study coordinator for the ones that are in the hospital. So you won't have to do any additional assessments or anything like that from that perspective for the study itself. As far as the projected timeline, before we launch this into 12,000 patients, we want to make sure it works. So we do a mini version, which is called the feasibility study. And there's about 300 patients that are going to just be at University of Michigan and WashU St. Louis, since we're the 2 coordinating sites. We want to work out all the kinks and make sure we're rolling out a really robust, easy to follow protocol for folks. And so the feasibility stage has technically already started. We started our educational kind of campaigns with the residents and CRNAs and attendings earlier this month. And then wanted to make sure we reached out to you all, and then we'll also be reaching out to East Ann Arbor or Brighton, whichever one gets selected to be participating for the PACU teams as well. And so the first study patient is going to be enrolled at the beginning of August. So we'll start seeing these patients come through, but just wanted to show you that this is a many-year study. The first part's the feasibility phase, and then the full study, you're going to get another wave of patients coming through for the same project. Later on, probably starting in 2023. And so for a feasibility study, we're looking at, will this study work? And so we say, will we get enough patients to enroll or agree to participating? And then also, will we be able to actually deliver the randomized treatment? If we say, please give a tiva, does a tiva actually happen? Or if we say, do we ask for volatile, does a volatile actually happen? And we're hoping for at least 80% of the time that actually is true. And so for how many patients and which sites? So adult patients undergoing elective non-cardiac surgeries over 60 minutes, meaning that not like ERCP super quick down an NPU, requiring general anesthesia with either an endotracheal tube or LMA. And we're really focusing on folks here at UH and then either Brighton or East Ann Arbor in this feasibility phase. We're not going to Mott just because it's a slightly different population over there and we want to study adults. But as far as the number of patients over the next year, we'll see about 150 patients come through, half of which will be randomized to tiva, half of which will be randomized to volatile. That's about 1 study patient a day or even less, as far as like excluding weekend days and things like that. So it's not going to be a constant thing. You may never see one of these patients, especially in the feasibility phase, but we want to make sure everybody's looped in with a few key points. And so the per protocol treatment is either administering tiva or VolatilE anesthesia. You won't be administering any of these things, but we do ask to remember that patients are blinded to the treatment group. So when we're giving, handoff in pre-op or, handoff in post in PACU, making sure that we can tell you, what we've given and everything, but we want to make sure if the patient asks, we say, oh, actually, that's something that you said that you were okay not knowing for participating in the study, because they knew that they weren't going to know which one they got when they enrolled and consented. So that's not us being sneaky. That's just good science of blinding everything. And so we ask like, oh, hey, oh, you're nauseous. Oh, that's weird. You shouldn't be nauseous. You had a tiva. We don't want that kind of thing to slip, which we could be very guilty of ourselves as well, especially in pre-op. And so for the propofol group, they're going to be getting propofol-based anesthesia with other opioids like Remi or Sufenta or fentanyl. And then we ask that they don't administer volatile agents, including nitrous. And for the inhaled group, we just ask that they at least give half of the general anesthetic is volatile-based. And so there's a checklist that they'll be filling out in the ORs. And so that's what we have here about like undesired movement. If there's other problems like prolonged wake up or things like that, they can note that on this checklist from that standpoint, which is nice. For each study patient, we're getting feedback there. And then also in the recovery room, if the coordinator may come in the PACU or later in the day up to the floor. So if you see the study coordinator or somebody who looks like they may not know their way around here completely with the PACU slot numbers or anything, they're participating in this study and they'll be conducting some assessments about how the patient's feeling and nausea and things like that. And so we ask that if they ask you any questions about like if they got any antiemetics, for instance, that you answer those, but otherwise they'll just kind of be a fly on the wall until they're intervening for their assessment. So no additional assessments from your perspective. We have a few resources that we've listed here. These are all living on the MPOG website, which is a multi-center perioperative outcomes group, which is a research group I work with that is kind of like the data hub for all of this data collection because it pulls stuff from the EHR really nicely. And so there's a lot of educational things for mostly like the anesthesia providers on how to safely conduct a TIVA. But if you're curious about it, like please take a look. They're pretty short videos, like on the order of 10 to 15 minutes. So we wanted to make sure you were aware of these resources as well. And then there's a study homepage on the mpog.org Thrive Info site. And we have an upcoming M&M on 7/28 as well. And so the biggest question that like I at least anticipated, well, what if my patient had like tells me they had intraoperative awareness or something as part of this? You know, in our normal PACU, that could happen as part of the study. It could also happen. It's unlikely just because it's a very rare event and there really isn't a difference in intraoperative awareness between the two types of anesthesia that's been measured or documented. And so if you do find that there's some sort of intraoperative awareness, just reach out to the in-room anesthesia team and they'll know how to direct the patient to therapists and the study coordinator to record that event. But just like you would regularly, you'd reach out to the in-room team. So normal processes of care from that perspective. So nothing's different there. You don't need to page an additional number or things like that. They'll take care of making sure that's documented and passed to where it needs to be. That's it. If the study coordinator stops by, you can mention it to them while they're there, but they'll be asking the patient specifically about those things as well. And then if you have any questions, you can email askthrive@umich.edu. And that's our Thrive email account. If you have any follow-up questions or things that maybe went not as planned that you think we could improve on, we would love to know in this feasibility phase. This is the bumps in the road phase that we are trying to smooth all of them out. So if we don't know they're there, we can't fix them. So if there is something, don't hesitate to reach out. Great. Any questions about anything?
Besides the awareness, is there anything else that comes to mind that like might be a potential complication? Or,
yeah,
I don't know. I guess that's probably the biggest one. Like,
yeah,
you know, not as deeply sedated.
right. And we're
Or
encouraged.
nausea, I guess, or
Exactly. Yeah, that's the one I was going to throw out was nausea, just because we know that TIVA is slightly better or is better for postoperative nausea and vomiting history, that we use that primarily for folks with PONV. So even somebody who didn't have a history of PONV can still have post-op nausea and vomiting. So if that's the case, we'll be looking through the regular documentation of giving antiemetics in the recovery room and things like that. And the study coordinator will be asking the patient about that specifically when they come by as well. So that's on our assessment of how they're recovering, includes questions to make sure that we capture intraoperative awareness if it were to happen, as well as post-op nausea, vomiting. And we're not anticipating that the rate of intraoperative awareness is going to go up or down or anything. It's probably going to be just the same as before. And to help protect against people not being as familiar with TIVA at first, we've done a lot of education with all the residents and the CRNAs and the attendings too, just because some people aren't used to that. And so we've been helping from that perspective. And then also we're encouraging SedLine use, which is a sort of it's an EEG monitor, and it can help you assess depth of anesthesia. And so that's something that we're encouraging folks to use if they're running the full TIVA. Yep. So again, not anticipating that, but it's on our radar because it's one of those devastating complications. And actually, one of my favorite parts about the study is that we've had patient partners the whole time, even from before the grant was funded. And that includes folks who have had intraoperative awareness events and have had dreamy anesthetics, great, and also bad nausea, vomiting, things like that. And they've all been contributing into the design of the study and giving their feedback, which I think is really cool and really helpful to just to create something that's really beneficial to our patients. Yeah.
For the reassessment, like with our patients today, like we usually call them the day after as well, and they kind of let us know whether they had any problems with anesthesia. Is that something to consider later on as well? Because if you're going to be calling a patient, I don't know if if you mention to them, hey, you're going to be call a little bit more often than,
Yep.
or more times than not.
Yes.
But that's a good way also to find out, because whenever we do our post-op, they let us know whether they had like immediate post-op nausea or vomiting, or they did it the day after.
Right. And which is not uncommon. Yeah, they have it once they got home and like, oh, I felt fine until I got in the car, and then the car started moving and I puked everywhere. And so they're actually assessing, we have multiple assessments from 0 to 90 days. And so it's post-op day 0, 1, 3, 7, 9, and then I'm making up numbers at this point, but then it's sporadic through, but it's very rapid in the first week of surgery. There's 3 different surveys in that first week.
And will the patient have the contact information? So the pre-op caller could say, hey, look at your, is it on the ABS? You probably hand them a piece of paper.
Yeah, they'll have all of that.
You know, if you're having issues or concerns, here's contact these guys. Okay.
Right. And if there's an intraoperative awareness event or something, just out of curiosity, if you are talking to a patient the next day and they're like, oh, I remember things from my procedure, do you usually then reach out to the anesthesiologist who is in that case to let them know? Or do you just put it in the chart? Or it's such a rare event that, yeah.
I know we can do anything.
Or document an event.
Yeah.
Yeah.
So I was like, whenever we had any like, not negative feedback, but something that be of concern from the patient or whatever, we can put an event on the computer, like a safety report.
Yeah, a safety report is a great way to document that. You can always feel free to reach out to the anesthesiologist. You can just send them a quick page and be like, hey, this patient had an issue, call me back, so they can fill it in. Because they'll do that at the CDC if they're like, hey, I think a doctor should talk to them about something and follow up. Because especially intraoperative awareness, it can be incredibly traumatic. And so we want to make sure they get into therapy and yeah.
All our staff to do a safety report.
Perfect.
So, but after that, I don't know, I guess we don't know the involvement of like how much further anesthesia takes.
Right.
Like send a letter, I guess.
Yeah, we send a letter, we give them therapy, or recommendations to if they want to see a therapist to talk about things. Some people are unbothered by hearing some voices because they didn't have any pain or discomfort. But we say like awareness with recall is the negative thing where we're aware, you remember, and then there's kind of a distressing component of it that we ask about next. And if they're distressed or could be distressed later, because it can kind of change too over time, they'll have the resources at their fingertips to do that. But that's all. Then this is all consistent with your standard protocol. So there's nothing to change there, but it's just to be aware of what's going on and it's happening. I wanted to make sure this wasn't happening around you, but with you as far as the study goes, because it's going to be a couple years as well for the full study. Yeah. Any other questions? All great questions. All right, I'm gonna escape out of this, and I see in the chat here. Oh, you mentioned you are not including MOT in this study. However, our adult OB-GYN surgeries has a huge issue with PONV. That would be a great group to include. And I agree with you that this would be a great group to include, but actually if they have a history of postoperative nausea and vomiting, they actually are excluded from this study. And so the reason is that at the point of inclusion in the study, we have to say, this patient, it's safe and the best care to get either one of these things. So if they have a history of postoperative nausea, vomiting, they're actually excluded because TEVE is better for them, and we know that. And so that's not fair to that patient to then potentially subject them to a volatile anesthetic and have them puking and packing for 3 days. You know, so that's why we're not including patients with PONV. And then as far as going to MOT for the adult population, it's honestly so few operating rooms and patients compared to UH that it's not worth kind of going out to an additional site in this feasibility phase. Now that could change for the full study when we're doing many more patients, but in this feasibility phase, we wanted to kind of be able to hone in on everything, make sure we're assessing everything properly, and limiting the number of sites is easier to do that in from that perspective. Did that answer your question, Mike? Okay.
Yeah, that's good.
Okay, thanks. And is there a specific way we as nurses should report side effects like PONV? We're not asking you to do anything outside of your standard clinical practice. And the study coordinator will be specifically asking about all of those things in an even more granular way than the way you were documenting it now, which is we capture any antiemetics given, or if PONV is documented or written in the notes. But that'll be specifically asked about from the study coordinators. Oh, great. Thanks, Sarah. Awesome. All right. Thanks, everybody, for your excellent questions.
Thank you.
Yeah, thanks for having us. Oh, sorry. I was probably like walking off the screen at some point.
I
I think it was, yeah,
Like
I'm
a
gonna
mobile
grab
person.
a few more things, but-
Awesome.
We
Thank you so
appreciate
much.
it. Yeah, do you want to grab your?
Oh, I
flash
do want my flash drive.
Yeah, you might need that.
Hi,
to track
Tony.
it down?
You mean you don't want all my random presentations that I was worried I wouldn't have copies of? Okay, I can't minimize.
Oh, we can just. let's see, you can enter.
There we go. Close that. And I'm gonna put a copy
Just on
copy
my.
on your desktop. Is that okay?
Perfect.
It'll be easy to find.
So do you want me to send an email out about this? And
If you want,
Or you can, it
or
doesn't
I
matter.
can include it all with like the video from today's presentation.
yeah, that's a great idea.
That way it's all
All
kind of.
together. Yep, perfect.
Great. It's labeled as Thrive is the first letter or the
Okay.
first where is
Survived it.
all right, thanks everybody.
Thank you
Yeah,
for
thank
coming.
you.
Do you know your way out of here?
Yeah.
Yeah, nice to meet you too. And we're just trying to make sure everybody's like looped in as much.
Yeah, no, we appreciate you including
Yeah,
nursing because
even
that
though
doesn't
it's not-
always happen, even though it's not really much for us, but still.
Sorry.
it's- Oh, geez, yeah,
I
don't,
probably shouldn't leave that either.
Yeah.
I'm like,
I was gonna say if you're post-call, you're tired.
but yeah, because it.
Thanks,
isn't
guys,
necessarily
everybody on
a massive
Zoom.
money,
Mhm.
but, otherwise
Don't give
it's-
away the secret.
Yeah, exactly.
Yeah,
Yeah.
see, and I think in our email or your email, you should include, if the patient asks, remember when you were consented, you agreed to be blinded to what you were receiving.
Yeah.
So that, and then they can discuss further with the study coordinator. I mean,
Yeah.
that would be
Yeah.
the standard like
Yeah,
response. I think we should probably.
Yeah, and because it's all, that's all very true and fact based.
Mhm, yeah.
Remember, you consented, then
Mhm,
you're gonna know, that's
mhm.
part of the deal, you know?
Yeah.
And if they want to withdraw from the study, they can. you
Yeah.
know,